Welcome everyone and good afternoon. Thank you for joining the Syphilis During Pregnancy and Congenital Syphilis Prevention Initiatives webinar hosted by HCT with the presenters Dr. Crowder and Dawson Groves. My name is Megan Arias and I am the Training and Organizational Development Manager here at HCET and will be moderating the webinar today. So I'm just going to briefly touch on who we are at Healthcare Education and Training. HCT's mission is to provide comprehensive program development, education, and training to improve reproductive and sexual health outcomes. And we're an organization of passionate people who are proactive in their belief that access to evidence-based, medically accurate reproductive and sexual health education, training, and care is a fundamental right. Next slide, please. Thank you. So this webinar does have closed captions available. They will be popping up on the PowerPoint themselves when the presenters are talking, but you can also enable them through Zoom by hovering over your main screen. There should be a button at the bottom that says, I believe it actually says show subtitles now. We haven't had this updated yet, but it should say show subtitles or live transcript, whichever version you have, and you can click that and hit show subtitles and change those settings by clicking subtitle settings within that tab. Next slide, please. Thank you. So throughout the presentation, we encourage you to send your questions via the Q&A box. And to pop that open, you're gonna once again hover over that main screen and there should be a button at the bottom that says Q&A. And that box should pop up for you. We encourage you to send questions through the Q&A because you can ask them anonymously if you want to do that. And we'll hold all questions till the Q&A portion at the end of the webinar once content has concluded. Next slide, thank you. So please be sure to follow us on various social media accounts to keep up to date with the newest information and events. Next slide. Thank you. So just a quick bit of housekeeping information. Link to complete today's evaluation will be sent to you at the end of this webinar once it's concluded via email. There'll also be a link sent through chat and a QR code at the end. That'll be up on the screen for you to access. Your feedback is greatly appreciated on our end. It helps us guide what we are putting out for you all and making sure that it's what you want. And if you have any, if you want any of the archived presentations that we have or a list of upcoming events, those can be viewed on our website at hcet.org. And if you have any technical difficulties during this presentation, please feel free to reach out to myself via Q&A or chat, or you can contact updates@hcet.org and we can get you helped out. Next slide, thank you. So this webinar does have nursing contact hours available, and to receive nursing contact hours for this presentation, you'll need to attend the entire webinar, complete the participant evaluation and post-test, and complete the nursing contact hour form and email it to Kay Bradford. And I'll run through this again before we close out for the day. And this information will also be included in that follow-up email. So no need to scramble to write it all down at the moment. Next slide. Thank you. So no one with the ability to control content of this activity has a relevant financial relationship to disclose with an ineligible company. Next slide. All right, so I'm going to introduce our presenters for today. We have Dr. Crowder and Dawson Groves. Dr. Crowder received his medical degree from the Indiana University School of Medicine. He's board certified in family medicine, and before working for the Indiana Department of Health, Dr. Crowder worked with the Franciscan Health beginning in 2019. From 2019 to 2020, he worked as a family physician and a travel medicine physician. And in 2021, January of 2021, he became the medical director of employee health for the Franciscan Central Indiana region and the Franciscan Travel Medicine Department. He was also the medical director of the Franciscan Healthy Access Program and the medical supervisor of the Immunization Clinic. And Dr. Crowder's medical specialties include travel and tropical medicine, employee health, public health, and family medicine. Dawson serves as an STI prevention program specialist at the Indiana Department of Health. Dawson's role includes expert oversight in 26 Indiana counties throughout the state. And since joining the Indiana Department of Health in December of 2021, Dawson has implemented heightened congenital syphilis prevention efforts, led the revision of the programmatic policies and procedures, and curated a maternal and congenital syphilis tracker that features automated email reminders to ensure consumers follow up, and expanded prevention services to 21 local health departments from January to April in 2023. So without further ado, I'm going to pass things over to our presenters to get us started.
Well, thank you very much, Megan. Thank you all for taking the time to join us today to hear some things from us about congenital syphilis. Next slide, Dawson. So to kick this off, we always like to put it in perspective as far as what our mission and vision are here at the state, but especially thinking about our mission today to promote, protect, and improve the health and safety of all Hoosiers. I think we can't do this in any larger way than thinking about saving babies from congenital syphilis. So very grateful for you all to be able to join us today. Next slide, Dawson. So to introduce this, I think it's good to put it into the bigger overall context of what we're seeing in the United States, as well as generally what we're seeing here in the state of Indiana. And so I think many of you are probably aware about the increase that we've seen in congenital syphilis cases nationally. There was a MMWR that was published at the end of last year from the CDC that mentioned a 755% increase from 2012 to 2021 across the United States of congenital syphilis cases. And we think that about 9 in 10 of these cases are due to lack of timely testing and adequate treatment. And about 4 in 10 of these are due to lack of prenatal care in the mother as well. And what we've seen here in Indiana is a pattern that's fairly consistent as far as an increase overall. And if you look at our preliminary data from 2023 and you compare that back to 2018, we've gone from 2 cases to 48. And so although the number is small, that is a 2,300% increase. And so here at the state of Indiana, we have started a congenital syphilis task force to try to address this. And we have several initiatives that will be forthcoming as far as some communication coming to all of you, but really based on a lot of the things that Dawson will be educating you about today. And so with all of that context being built and introduction, I'd like to go ahead and kick it over to Dawson, who is our expert and knows more about syphilis than just about anybody I've ever met in my life. So I'm sure he'll be able to give you lots of great information. So go ahead, Dawson.
Thank you. Thank you, Dr. Crowder, and thank you to HCET for hosting today's webinar. Again, my name is Dawson Groves, and I am an STI specialist here at IDOH, and I'm happy to join everyone today. The goal of today's webinar is to provide an overview of the increasing numbers of syphilis and how this impacts the number of reportable congenital syphilis cases. This presentation will cover the prevalence of syphilis, background and transmission of syphilis, test for syphilis, staging of syphilis for public health surveillance, interpretation of syphilis results, and IDOH's congenital syphilis prevention initiatives. The appendix of this presentation includes disease intervention specialist contact details, an example of interstate communication control record processes, and CDC's clinical considerations for syphilis during pregnancy and congenital syphilis follow-up. So let's get started. So congenital syphilis is a condition caused by infection in utero with Treponema pallidum. Congenital syphilis can be reduced through timely testing and the provision of adequate treatment of syphilis during pregnancy. Congenital syphilis can lead to stillbirth, miscarriage, or neonatal death, and surviving infants who are not adequately treated may develop blindness, deafness, developmental delay, or skeletal abnormalities. So some background of syphilis. Syphilis is a sexually transmitted infection caused by the bacterium Treponema pallidum. Syphilis cases reached an all-time low between 2000 and 2001. However, cases continue to increase and are now at an all-time high in the country. In 2021, there were 176,713 new cases of syphilis reported in the United States. Syphilis can be transmitted from person to person by direct contact with a syphilitic symptom. Syphilis can spread during vaginal, anal, and/or oral sex, and pregnant patients can also transmit syphilis to their fetus, therefore resulting in congenital syphilis. The sexual acquisition of Treponema pallidum occurs following the exposure of mucous membranes or microscopically abraded skin during sex. The average incubation period is approximately 3 weeks, but can be as short as 10 days or as long as 90 days. During this time, tests can remain non-reactive and persons are not considered to be infectious. But without post-exposure prophylaxis, persons exposed will progress to primary syphilis, symptoms of which are on the bottom of the screen here. Following exposure, a localized infection occurs at the site of inoculation, resulting in the development of one or more primary syphilis chancres, photos of which are on the right hand of the screen. Without treatment, primary syphilis chancres will heal spontaneously within 1 to 6 weeks, after which persons may enter a short asymptomatic period before the onset of signs or symptoms of secondary syphilis. Secondary syphilis presents as a disseminated systemic form of infection. Within hours after inoculation, spread of the spirochete of Treponema pallidum occurs to most organ systems of the body. And since Treponema pallidum best proliferates in lower temperatures, most clinical signs and symptoms present as skin and mucous membrane eruptions. If left untreated, manifestations of secondary syphilis typically resolve within weeks, but some may persist for months, after which a relapse of secondary syphilis signs or symptoms may occur, especially during the first year of infection. And therefore, persons who acquired syphilis within the previous year are considered to be infectious, even if asymptomatic at the time of diagnosis. A localized host immune response can lead to bacterial clearance from primary and secondary symptoms, which will ultimately resolve. However, these responses fail to completely eliminate the spirochete systematically, resulting in ongoing asymptomatic and latent infection. Once acquiring syphilis, the infection typically follows a progression of stages. So we have early syphilis and then late syphilis. Early syphilis is characterized by 3 stages, and it is considered infectious when it's less than a year. So for primary syphilis, it is infectious with active signs and symptoms, and secondary syphilis is also directly infectious with active signs and symptoms. Early non-primary, non-secondary syphilis can potentially be infectious. Late syphilis is characterized as a stage of the disease greater than 1 year. And we have 2 stages of this, latent syphilis and then tertiary syphilis, both of which have no active infectious signs or symptoms. So after acquiring syphilis, the infection will progress through stages. These being primary, secondary, late, and then tertiary, if treatment is not administered. Persons with primary and secondary syphilis typically seek treatment to resolve the symptoms with syphilis. T. pallidum can infect the central nervous system, which is referred to as neurosyphilis during any stage of infection. Neurologic findings of syphilis include syphilitic meningitis, such as cranial nerve dysfunction, meningitis, stroke, and acute altered mental status. These are typically evident within the first few years of infection. Late neurologic manifestations include muscular weakness, and the degeneration of the nerve cells and fibers that carry sensory information to the brain. And these late manifestations typically occur 10 to 30 years after infection. So the next few slides cover the surveillance case definitions of acquired syphilis and then congenital syphilis. So our first stage is primary syphilis, which is characterized by one or more ulcerative lesions, also called a chancre, and a reactive non-treponemal test or a reactive treponemal test. Secondary syphilis is characterized by localized or diffuse mucocutaneous lesions, mucus patches, celata, or alopecia. Secondary syphilis requires a reactive non-treponemal test and a reactive treponemal test. Early non-primary, non-secondary syphilis is a stage of syphilis in which syphilis has been acquired in the past year, but there are no active signs and symptoms of primary or secondary syphilis. So for persons with a prior history of syphilis, this means a current non-treponemal test titer demonstrating a 4-fold or greater increase from the last non-treponemal test titer, unless there is evidence that this increase has not been sustained for greater than 2 weeks. And then for persons who have no prior history of syphilis, this means a current reactive non-treponemal test and reactive treponemal test, and evidence of having acquired the infection within the previous year. So when we say having acquired the infection within the previous year, this means there may be non-reactive testing in the past 12 months, historical signs or symptoms of primary or secondary syphilis in the last 12 months, a partner with early syphilis in the last 12 months, or sexual debut in the last 12 months. And then lastly, late syphilis is a stage of syphilis in which initial infection has occurred greater than 12 months previously, or in which there is insufficient evidence to conclude that infection was acquired in the last year. So this translates to no prior history of syphilis and a current reactive non-treponemal test and a current reactive treponemal test, or a prior history of syphilis and a current non-treponemal test titer greater than 4-fold from the last titer, or clinical signs and symptoms and lab results that are consistent with neuro-ocular, otic, or late clinical manifestations of syphilis. And then congenital syphilis is a condition caused by infection in utero with T. pallidum, and reportable cases of congenital syphilis are specific to treatment adequacy in the mother and or clinical evidence of congenital syphilis. This may be on the basis of physical exam, x-rays, or lab findings. And then adequate treatment for syphilis during pregnancy is defined as the completion of a penicillin-based regimen in accordance with CDC treatment guidelines appropriate for the stage of infection that was initiated 30 or more days before delivery. And then missed doses, which is summarized by doses less than 7 days or greater than 9 days, are not acceptable for pregnant persons receiving therapy for late syphilis. If this interval is too great or too little, the entire course of therapy must be restarted. So for the detection of syphilis, the use of only one type of test is insufficient for diagnosing syphilis and can result in false negative results among persons tested during primary syphilis and false positive results for persons without syphilis or persons who have previously been treated. Treponemal tests detect the antibodies to treponema pallidum proteins, whereas non-treponemal tests detect antibodies directed toward antigens, damaged host cells, and treponemes. Non-treponemal tests reflect the activity of the infection and are reported as a quantitative titer, for example, 1 to 2, 1 to 4, 1 to 8. These reflect the number of dilutions in which activity is still detected. Seroconversion of syphilis tests typically occur around 3 weeks, but can take up to 6 weeks. Persons who are diagnosed with syphilis and have reactive treponemal test will typically have reactive treponemal test for the remainder of their lives, regardless of adequate treatment or disease activity. Therefore, treponemal tests cannot predict treatment response and should not be used for this purpose. The direct detection of syphilis, called confirmed syphilis, can be accomplished with dark field examinations and molecular tests in which treponema pallidum is directly identified from lesion specimens or tissue. So this can be completed with early syphilis, in which the patient is symptomatic, or congenital syphilis. A presumptive diagnosis of syphilis requires the use of 2 lab tests, a non-treponemal test and then the treponemal test. Examples of treponemal tests include TPPA, EIAs, CIAs, and then for non-treponemal tests, examples are VDRL and then RPR. The non-treponemal test antibody titers are used for monitoring treatment response and should be reported quantitatively. A 4-fold change in titer, which is equivalent to a change of 2 dilutions, for example, from 1 to 16 to 1 to 4, or from 1 to 8 to 1 to 32, is considered necessary for demonstrating a clinically significant difference between the 2 test results. It is preferred that sequential tests for persons diagnosed with syphilis are performed using the same testing method, for example, a VDRL or RPR, and by the same laboratory. Quantitative non-treponemal test titers are expected to decrease after adequate treatment and can become non-reactive over time. The sequencing of syphilis tests typically follows one of 2 options, referred to as the traditional algorithm or the reverse sequence algorithm. The traditional algorithm starts with screening with a non-treponemal test, a RPR or VDRL, and then if reactive, the reactive non-treponemal test is confirmed with a treponemal test. The reverse sequence algorithm for syphilis testing is useful for identifying persons who have previously been treated for syphilis, those with untreated or incompletely treated syphilis, and those with false positive results that can occur with a low likelihood of infection. The reverse sequence algorithm begins with screening with a treponemal test, and then if reactive, the reactive treponemal test is reflexed to a non-treponemal test. The caveat is that if the non-treponemal test is non-reactive, it is then reflexed to another treponemal test, and if that treponemal test is reactive, then the person is confirmed with a previous history of syphilis, whether it be untreated or previously treated. So the quantitative value of a non-treponemal test titer is used to gauge treatment response and follows the structure of a bell curve. As such, the initial value of a non-treponemal test can become non-reactive. Eventually, the quantitative value will peak and then begins to decline over time. And it is possible that a non-treponemal test becomes non-reactive even without treatment. And this is because of the natural history of untreated latent syphilis among those who are immunocompetent, typically follows the rule of thirds, in which approximately 1/3 of persons seroreverted to a non-reactive non-treponemal test with no further evidence of infection. 1/3 remain reactive by non-treponemal tests, but remain free of signs, symptoms, or complications. And then the remaining 1/3 eventually developed evidence of tertiary syphilis. And now we will dive into an example for staging syphilis infection. So here we have an example of January 1st, 2023. A patient reports for syphilis testing. Their TPPA is reactive, and their RPR is reactive with a quantitative titer of 1 to 4. So based on this information, there's not enough to determine if the patient has early syphilis or late syphilis. However, on the date of exam testing, the clinician reports a painless ulcerative penile lesion. The patient can now be staged as a primary case of acquired syphilis. And then on the same day, the clinician administers 2.4 million units of bicillin LA, and this is adequate treatment for primary syphilis. So on May 1st, 2023, the patient's titer has decreased to 1:1, which demonstrates an appropriate response to treatment. And then as another example here, if the 1:1 from May 1st of 2023 increases to 1:64 on October 1st of 2023 without signs or symptoms, this is a fourfold increase in non-treponemal test titer, which demonstrates a new case of acquired syphilis. So just with this increase, the patient could be staged as an early non-primary, non-secondary case of acquired syphilis. And then if it's documented that they have signs and symptoms of secondary or primary syphilis, then that could justify a stage of secondary or primary syphilis. So now to move on to IDOH's congenital syphilis prevention initiatives. On screen is the surveillance case definition of congenital syphilis, which is broken down into maternal and infant criteria. So therefore, many of IDOH's congenital syphilis prevention initiatives are structured to take all measures to prevent the maternal criteria of congenital syphilis from being met. And then the secondary goal of the maternal criteria not being met is that it reduces the infant criteria from being met. Worth noting is that these criteria are not mutually exclusive, and that maternal treatment adequacy does not eliminate that an infant meet the surveillance case definition of congenital syphilis by infant criteria. Syphilis testing at the first prenatal care visit at 28 to 32 weeks gestation and again at delivery are important for preventing congenital syphilis, because all of these timeframes allow for the detection of syphilis during pregnancy and therefore timely connection to treatment. Testing at 28 to 32 weeks gestation is important because adequate treatment by CDC is defined as the completion of a penicillin-based regimen that is appropriate for stage of infection that has been initiated at least 30 days before delivery. So that third trimester testing allows for any possible detection and then treatment of syphilis. Another prevention initiatives is verifying treatment adequacy. And this is again because infants born to persons with untreated or inadequately treated syphilis at the time of delivery are classified as probable cases of congenital syphilis, and appropriate documentation of treatment is essential for determining treatment adequacy during pregnancy. Those with reactive syphilis results should be considered infected unless an adequate treatment history is clearly documented, and then sequential non-treponemal antibody test titers have decreased as recommended for the syphilis stage. So this may include those with persistent reactive treponemal results and non-reactive non-treponemal test results. Bicillin LA is the only known effective antimicrobial for treating fetal infection and preventing congenital syphilis. And there are no alternatives to bicillin LA during pregnancy. Those who have a history of penicillin allergy must be desensitized and treated with bicillin LA according to their syphilis stage. The optimal interval for spacing between doses of bicillin for pregnant patients receiving treatment for late syphilis is 7 days, and those that are less than 7 days or greater than 9 days apart are not acceptable. If the dose is missed or too great or too little, then the entire course of therapy must be restarted. And And then again, to reiterate, persons diagnosed with syphilis who are pregnant must be adequately treated for their surveillance stage of syphilis in accordance with the treatment recommendations set forth by CDC. And part of determining treatment adequacy is that if persons require more than one dose of bicillin LA, IDOH requires that each dose is documented separately with the date that treatment was administered. And if a patient reports a history of syphilis and previous treatment from out of state, but records are unsuccessfully located or record search results are negative, the patient must be retreated according to their syphilis stage. And if the patient reports a history of syphilis from out of the country and does not have documentation of treatment, the patient must be retreated according to their syphilis stage. Moving on to the maternal and congenital syphilis investigation tracker. IDOH maintains a maternal and congenital syphilis investigation tracker. All persons with syphilis who are pregnant are reported by disease intervention specialists for tracking through pregnancy. The tracker features reports by case status and action required, such as treatment need, follow-up needs, etc. The tracker features automated email reminders to the investigator assigned to the case, copies the district STI specialist, and maternal and congenital syphilis prevention coordinator. The tracker also emails notification of congenital syphilis case status to IDOH's STI epidemiologist when it is approved to close. So the next few slides are examples of the CS tracker. The first few are the back-end views of the notification. So this first one would initiate this notification based on the email address added there. And then this view shows the last time that the investigation was reviewed, if the maternal and congenital case is approved to close, and then the investigation jurisdiction and STI district. Also showing case status comments, and then the criteria for which congenital syphilis is reported there. And then tracking of maternal estimated date of delivery, 28 to 38 week titer due date, and then infant birth status and date of birth. Here are the reminder templates for the maternal case investigation and then congenital investigation. And then this is the front end view of what a disease intervention specialist will see when those reminders are initiated. This is the approval for closure template. And then the link at the bottom there goes to a live web page in which clicked will present this page. Includes the bulk of today's content. There are many appendices, topics for DIS contact information, for connecting patients to partner services, and then CDC's recommended clinical follow-up for syphilis during pregnancy and then congenital syphilis. But we have lots of time for questions, if anyone has any.
We have a few in the chat, and I also see someone's hand raised, which is also an option. They are allowed to come off of mute if they raise their hand to ask their question out loud. So the first question we have is, where are we with the shortage of bicillin LA?
So IDOH has earmarked supply of bicillin for agencies that employ disease intervention specialists. And this is acquired through the HRSA 340B drug pricing program. So part of the reason the DIS contact map is included is for the ability to connect patients to those DIS. And the provision of partner services will enable consumers to receive that 340B bicillin.
Thank you. Next question we have is, are delivering facilities able to assist if a patient is on the investigation tracker?
So long as the pregnancy status has been reported with those lab results, the DIS will report that when they are working the case.
Okay. Next question is, beyond surveillance, what else is IDOH doing to address CS in our state? And then what innovative strategies are being explored?
I think Dr. Crowder could answer this as well, but part of Dr. Weaver's task force for congenital syphilis and syphilis overall includes a lot of communications to providers, and I'm excited to see that, and I'm grateful for both Dr. Weaver and Dr. Crowder's support in that. So more to come on that, but we have been working hard with the syphilis task force and getting those materials compiled, updated, and then published to the IDOH website.
Yeah, and I'd be happy, excuse me, sorry, to add a couple things to that as well. Dawson, you're exactly right. I think we're really following suit with what's happening nationally, which I think is, trying to identify, patients that may be infected with syphilis in areas where maybe they're not always traditionally being seen. So especially like during pregnancy, outside of areas like the obstetrician visits, excuse me, but maybe like emergency rooms, urgent cares, collaborating with hospitals to ensure like things such as opt-out testing would happen for an emergency room visit. But also looking at some of our community programs, so syringe programs, for example, where maybe we can do some testing. So really trying to meet people where they're at with this, to try to increase screening and treatment access. And so other things as well. And as Dawson mentioned, more communication hopefully coming soon with all of that, with more formal recommendations, but it should be, fairly wide ranging.
Awesome. It looks like we have Rachel who has her hand up, so I will have you come off of mute. Rachel, do you have a question you want to ask off of mute? Okay. I don't know if she wanted her hand up or not, but so we'll move on. And if you do, you can always raise your hand. Next question we have is, why is it that a person will always have lingering syphilis bacterium in their system even after successful treatment?
That is kind of consistent with even HIV and Hep C. Once the body has created those antibodies, they will typically always persist. The exception to that is if the infection is caught early and treatment is administered early. Sometimes we'll see both tests serorevert, to non-reactive, but typically the treponema test will remain reactive for life since those antibodies are always persistent. And then even if the RPR or non-treponemal tests remain reactive, so long as at least a fourfold decrease in titer has been demonstrated, that justifies an appropriate response to treatment. So even if that remains reactive, it doesn't necessarily mean that the person needs additional treatment unless they present with signs and symptoms or have a new exposure, etc.
Okay, next question is, if individuals are asymptomatic, are they still considered infectious if they acquire syphilis less than a year?
Yes, due to the sometimes primary and secondary syphilis can resurge and the symptoms can kind of come and go. And since early syphilis is the most infectious stage of syphilis, anyone who has acquired syphilis within the last 12 months should be considered infectious.
Okay, our next question is, most OB offices are performing the RPR early and late pregnancy. Do they need to perform TPTA testing also? And what testing on admission for delivery should be used?
So that sounds like the traditional algorithm is being used. And with that algorithm, I'll go back. If the initial non-treponemal test is non-reactive, then the sequential treponemal test is not needed. So here's that example again. If that initial RPR or VDRL is non-reactive, then a laboratory typically won't reflex to a treponemal test. But if it is reactive, then it is reflex to a treponemal test, whether that be a TPPA, EIA, CIA, IgG, IgM, FTA. I think the list could go on and on. But then from there, it would be reported. And then knowing that the RPR can become non-reactive even without treatment, that is where considerations for the reverse sequence algorithm may be implemented, with starting with that treponemal test so that those antibodies are always detected. And then if it's reactive, it would be reflex to a non-treponemal test. And then if that is reactive, it will be considered current or past syphilis infection. And then if the RPR is non-reactive, then it would be reflex to another more specific test, which CDC prefers the TPPA would be used in that instance. And then if that remains reactive, then the current or prior history of syphilis can be confirmed.
Next question is, when a patient is pregnant, is every syphilis case considered MS regardless of the length of time since initial diagnosis? And then EGPT was initially tested and treated more than 5 or 10 years ago. Is history the key component and time is relevant?
Yes, and there are, in the appendix here, I will surface to CDC guidelines. There we go. So for CDC recommends that all infants born to mothers who have reactive non-treponemal tests receive equivalent testing. So example, if the RPR for the mother is reactive at delivery, CDC recommends that the equivalent RPR be completed on the infant, and vice versa for the VDRL. With that being said, CDC advises that if after adequate treatment, the mother's non-treponemal test seroreverts to non-reactive, then there is virtually zero risk that an infant be born with congenital syphilis. So for that reason, IDOH endorses those recommendations in which we follow up on all infants born to mothers who have reactive non-treponemal tests, even after treatment. Did I answer all of that? I feel like there was a second part.
I can reread it really quick. So when a patient is pregnant, is every syphilis case considered MS regardless of the length of time since initial diagnosis? EGPT was initially tested and treated more than 5 or 10 years ago. Is history the key component and time is relevant?
Okay, yes. So kind of secondary to that, let's say IDOH discovers that a patient is pregnant. Our first initiative is to verify that they have been treated according to their syphilis stage. And then with that, I will revert to my answer before with still recommending that infants born to mothers with reactive non-treponemal tests receive the equivalent of that testing at delivery. Good question.
Next question we have is, some providers are hesitant to treat with bicillin because they are concerned about a patient receiving too much penicillin during pregnancy, specifically for patients who require 3 doses. Is it possible for a patient to receive too much penicillin?
I don't think I have an answer to that. I think that is where I would encourage the collaboration with your local DIS to establish the appropriate stage of syphilis for treatment, and then gauge the need for the sequential doses off of any potential history, their stage of syphilis, and then any known exposure for syphilis. I will note that CDC sometimes recommends, so for example, if someone has early syphilis, the recommended treatment is 1 dose of 2.4 million units of bicillin, and some jurisdictions have recommended an additional dose 7 days after that dose. So for that reason, I would say we would rather treat with 3 doses than 1 dose.
Next question we have is, what are the recommendations if a pregnant patient comes into deliver without prenatal care? How should testing be handled?
Similar to how it would traditionally be handled, I think and here CDC provides some clinical considerations for those situations. And it kind of is a hierarchy off of how they are constructed. So ideally, if the testing is non-reactive, then obviously nothing else would be done. But so there are 3 examples here. So this first one is a reactive maternal treponemal test with non-reactive non-treponemal tests during pregnancy. Second one is an isolated reactive treponemal test during pregnancy. And then the last one here is an isolated reactive treponemal test at delivery. So from here, they refer back to the clinical considerations for the infant. So in this case, they would recommend scenario number 1, which is this recommendation. So in that case, we would wait for those reactive results to be reported for DIS follow-up, and then follow up on the infant when those reports are received.
Next question we have is, what is the proper desensitization? Oh my goodness. Hold on, let me just,
Sensitization of
yes, treatment for PCNLA. I'm so sorry.
in this STI treatment guidelines down here at the bottom of the screen is CDC's recommendations for that, and they touch on that. Typically, they recommend that referral to a specialist be completed.
Okay, next question is, in probable congenital cases, how long after birth and treatment would an infant or child test positive? And will that also be a lifelong antibody reactive test?
So typically, infants are born with reactive treponemal tests, which is why the non-treponemal test is used in CDC's recommendations here, because those are essentially the measure of disease in found in the blood. CDC recommends that kind of also off these scenarios is eventually the infant should have a non-reactive non-treponemal test within a year, and CDC recommends that the follow-up be completed until the neonate has a non-reactive non-treponemal test. So again, I know there's a lot of words on the screen, but these scenarios really break down the evaluation and then follow-up for infants.
Okay, we have one more question, but we still have time. So if you have any other questions, please feel free to submit them and we can get those answered. But the last one that we have so far is, what strategies are being explored to increase the number of pregnant people accessing prenatal care to decrease the number of those who are showing up at delivery only?
I think that's almost with Health First Indiana, the Division of HIV, STI, and Viral Hepatitis has expanded testing services to 31 health departments just in 2023 alone. So making those STI services more accessible is the goal. And then consistent with that is the Congenital Syphilis Task Force, as Dr. Crowder has touched on, that the Emergency Preparedness Division and then the Division of Maternal and Child Health are very involved in that and have lent a lot of advice and considerations to expand these services to pregnant women throughout the state. So as we complete those task force projects, I'm excited to see how we can reach even more patients.
Awesome. So those are all the questions that we have at the moment. Like I said, we still have some time for people to ask any questions. So while people think of any last minute questions or comments, concerns that they may have and submit them, I'm just gonna quickly run through just some housekeeping things just before we all depart. But like I said at the beginning, this webinar is Nursing Contact Hour credit available. So if you wish to gain nursing contact hours, you'll have to do the post evaluation as well as complete the follow-up nursing contact hour form, which will be sent later today in that email with who it needs to go to and what information needs to be on that. So if you wish to gain that, please feel free to fill that out and get it sent back to us. And you can expect that in email along with our HCET event evaluation. And like I said, that is very beneficial to us just so we can guide our presentations in the future to meet the needs of you all. So I have posted in the chat the link to that evaluation. And I believe we can pull up a QR code shortly, just once I know that there are no more questions to be asked and answered. So I will give it just a few more seconds for those last minute questions to come through before we conclude today.
Megan, what slide was that QR code on?
It should be on the very last slide. Thank you. Okay, I'm not seeing any further questions. Oh wait, I do have questions. I apologize. I will read them. And you can leave that up. So this question is, wouldn't it make some wouldn't it make impact to have some kind of communication downwards, especially to OBs, to encourage / recommend everyone to get the syphilis and HIV screen at least 2 or 3 times during pregnancy to ensure we don't miss out on those that get infected after the first screen? And I don't know if that's a question or just a comment, but
Yeah, and I think that is kind of consistent with the recommendations with CDC in that they define the additional testing at third trimester and then at delivery by persons who live in a community with high rates of syphilis. And I think that can be somewhat confusing because the rate that is a high rate isn't necessarily defined. But I think when we look at the progression of syphilis rates in the state and in the country in the last decade, it can be considered by everyone. But again, part of that communication um, and is underway with the Congenital Syphilis Task Force. So again, I'm excited to see those documents published soon.
Next question we have is, has IDOH ever thought of using platforms such as Instagram or TikTok to educate individuals of the importance of prenatal care and STI testing to reach our youth?
I think with a lot of the communication that is underway, again, I'm going to keep saying the Syphilis Task Force, is definitely movement that is being made and consistent with that and the online presence of HCET's online presence with recommendations, CDC's recommendations, and then there's also Get Tested, Indiana.org. That is a great reference for sexual health references for consumers online. So those are also some considerations to use as references.
Next question is, did I hear you want the baby's non-treponemal test to go to non-reactive? How is this different than an adult who is successfully treated and stays at a 1 to 2 titer, for example?
Can you repeat that question?
Yep. Did I hear you want the baby's non-treponemal test to go to non-reactive? How is this different than an adult who was successfully treated and stays at a 1 to 2 titer, for example? And the question is in the Q&A, so if I'm not pronouncing words right, it can be viewed there as well.
Thank you. That is all part of CDC's clinical recommendations. So the disease intervention specialist follow-up is kind of a hierarchy based on the surveillance definition of congenital syphilis. So the first goal is to make sure that all pregnant women receive adequate treatment that is initiated at least 30 days before delivery and then completed before delivery. And then in this case, if the infant's non-treponemal test is reactive, the DIS would follow up for any signs and symptoms on the infant, and then any additional testing completed. And if the infant's test is non-reactive, then and the mom had received adequate treatment, then really no additional follow-up would be completed from the DIS standpoint. But again, those clinical considerations are all part of CDC's guidelines, in which the end goal would be that the infant have a non-reactive, non-treponemal test, just to rule out any possibility of congenital syphilis.
Okay, again, I'm at no questions in the inbox at the moment, so I will give it just a few more seconds for any last minute questions, comments, or concerns to come through. And I do apologize for my mispronunciation of words. I do not use these words every day, so they don't just roll off the tongue. So thank you for bearing with me. Another question we have is, so if a baby was born with congenital syphilis and later on, before they become sexually active as an adult and have a syphilis test done, will their test still be positive?
Personally, I have not seen that in real time with lab results. And I don't think I have an answer to that. I haven't seen that, but Dr. Crowder, do you have insights to that? I would think that the treponemal test, based on if the infant were to be treated according to the CDC's guidelines, would eventually become non-reactive, but I'm not, at least the non-treponemal test, but the treponemal, I'm not certain. I haven't seen that.
Yeah, that's what I would think would happen in that situation, is that the non-treponemal test should be negative. If treated accordingly. The antibodies, as far as the treponemal antibodies, are more difficult, I think, sometimes to predict, because I would expect reversion over time, mostly just due to, lack of ongoing immunogenic need, but there's a chance it could still be positive, although it should revert with appropriate treatment.
Yeah, because I do know that's part of the considerations why the non-treponemal test is used for kind of follow-up, because the IgG, IgM antibodies from the mother can persist for 6 to 12 months. So I guess based on that guidance from CDC, I would say maybe after a year, we would hope to see everything non-reactive.
It looks like we have someone raising their hand, so I will ask them now. I think it's Lydia. If you have a question that you want to ask off mute, you are more than welcome to do so now.
You've already answered my question, so we're good.
Awesome.
Thank you. I'll stop sharing so I can also see the Q&A.
Question we have is, will the IDOH congenital syphilis fact sheet be updated soon for providers?
Yes, we are working on updated all of the fact sheets. Consistent with that is expedited partner therapy guidance is being reviewed and updated as well. So excited to get all of that published for everyone soon.
Someone asked, how does one join the task force?
I don't know if I have an answer. I think Dr. Weaver assigned leaders, and then from there, the members have been kind of recruited from each division, and then as additional insights have been needed, we've kind of looped in other departments and other programs to offer guidance and expertise from there.
And you're free to email me if you're interested. I think we can always consider additions as well. So yeah, feel free to email me.
Thank you. Lydia, it looks like your hand is up again. Do you have another question you want to ask?
No, I didn't realize my hand was actually up. I apologize.
It's okay. Are they being translated to other languages, the fact sheets?
I believe so, yes. If there are specific suggestions for that, oh, sorry, I was trying to follow. If there are specific suggestions for languages that are not often represented, we would love to hear so we can get those translated.
And the next question is, if a reactive RPR infant is properly tested at birth, what testing besides follow-up titer value would be required?
So treated at birth based on risk. Again, that would be up to the clinical suspicion of the physician. Additional testing can include x-rays for bone deformities, CSF analysis for protein and white blood count, and I think I got them all. But really, it would be the clinical considerations from CDC would be used to gauge that. So eventually, we would hope to see the non-treponemal test be non-reactive, and then based on the maternal treatment adequacy and completion, and then based on any findings of congenital syphilis on exam, those follow-up considerations can be used to kind of guide additional testing.
It looks like there were some recommendations for translations, which I have noted that I can send over to you after the webinar. And then someone asked if this was being recorded and the timeline for that. I did not mention that. This webinar is recorded and will be available within a week. We are going through some website changes at HCAT, so it's takes a little bit more time to figure out our new route, but it will be uploaded to our website within a week from today. So please check back throughout to see it there. Next question is a preventative shot recommended for the baby when provider is not sure?
Again, CDC defines that as if follow-up is uncertain. So if follow-up for the infant is uncertain, to make sure that the non-treponemal test becomes non-reactive, then CDC endorses presumptive treatment in that case. And again, the treatment considerations are part of the appendix to the presentation for what those treatment regimens are. Thank you for that.
Next, someone asked if there are any follow-up questions after watching the recording, who is the best one to send questions to? If it is about the content, I would say Dawson or Dr. Crowder can let you know that. If it is about nursing contact hours, evaluation, the recording itself, you can follow up at HCET using updates at hcet.org, and we can get that. But I'm assuming it is about content, so I'll let you speak to that.
Absolutely. My email is listed in the questions part of the presentation, and then yeah, if Dr. Crowder is needed, I can loop him in
Next question we have is, would it be an automatic trigger to send babies who test positive for a perinatal center for the extended tests based on perinatal levels of care for those of us with level 1 or 2 nurseries?
Sorry, I'm trying to find that question so I can make sure I'm not missing anything.
That one is in the chat.
I'm not certain I have an answer for that. Again, based on the clinical suspicion on what testing is needed, those options might be considered if a lumbar puncture is needed or x-rays, etc.
That's probably what my answer would be as well, Dawson. I don't know that I would call it an automatic trigger. I think every case, is individualized with this. So we would need to probably evaluate what the clinical scenario is and what the resources are that are available. So yeah, case by case basis, I think that's where we could pull in somebody like Dawson as a disease specialist to consult for that.
Next question we have in the Q&A is, have you encountered any discrepancies between what providers decide to do or treat using the Red Book that don't align with CDC guidelines? And any advice on how to handle a provider who opts for something that doesn't exactly align with the CDC guidelines?
I think a lot of that may be due to clinical need for treatment versus the public health surveillance definition of adequate treatment. And something that I hope will help with that is an algorithm that we're actually working on that gauges the stage of syphilis and the need for treatment based on the surveillance definitions. And that's part of the syphilis task force as well. So hopefully that will help provide some guidance and clarity for treatment guidelines by CDC.
Awesome. I'm not seeing any more at the moment, but we do have just a few more minutes. So if questions you want asked, please send those in before we conclude for the day.
Thank you, Megan. I don't think I would have been able to keep up.
I've got double monitors, so I got loads of things open. Someone asks if the task force is specific to a certain state or it is nationwide.
Specific to IDOH, it was just a kind of a project that Dr. Weaver did to kind of focus on specific health outcomes just to make sure all consumers are connected and we are providing the most equitable access to care needed. So for right now, it is just IDOH, but I'm not certain if other considerations are being made. But hopefully more to come on that.
And I can add to that as well to tell you that just recently, really in the last couple of months, CDC has put together some partners to also do more of a national task force. But yeah, Dawson's exactly right. Really for Indiana, we're focused on the task force that is specific to Indiana, but several states also have a congenital syphilis task force as well. So I think there's a national and a local effort kind of both happening simultaneously.
Okay, well, I'm not seeing any more questions come through and we are at time. So thank you everyone for joining and being a part of the webinar today. And thank you, Dawson and Dr. Crowder, for such a wonderful webinar. Like they said, you can reach out to them if you have any questions following the webinar about content, and look out for an email from HCT that will just include evaluation, nursing contact hour information, and the slide deck for today compared to the one that was sent out this morning. There are some updates, so those will be included in that email. And if you have any questions about HCT or our content, please feel free to reach out to us. And with that being said, I hope everyone has a wonderful rest of their day. And thank you again to our presenters for such a great webinar.
Thank you.
Thank you.